G-Echo gas.
Hmm.
Hi, let me start again. Hi, I'm Wendy Spearman. Welcome to our G-Echo Gastroenterology Fellows webinar. This is hosted by the Gastro Foundation in association with Project Echo, University of New Mexico. And we have a very important topic today. It's going to be presented by Dr. Midhun John on MASLD, and I'm going to be facilitating it. It's quite a dense topic, and so we might go over the hour just slightly, but we hope to have a lot of interactions at the end of the presentation. So, Metin, over to you.
Just setting it up. 1 second, sorry. Are you able to see this, Prof?
Yeah, we can see it. Go ahead.
Fantastic. Awesome. Good evening, everyone. My name, as Prof mentioned, is Midhun John, and I'm a fellow in University of Witwatersrand and Simja. And today I've been given the great opportunity to speak about metabolic dysfunction associated steatotic liver disease, and commonly known as MASLD. Like Prof said, it's a very dense topic, so I tried to cover as much as I could so that I can give you essentially important information for us to take forward in our practice, as well as look into a lot of the things that we have in our future for MASLD as a topic. So before we move on to the actual core topic, I just wanted to revise a few things, especially for the junior fellows, including me. Is the progression of a steatotic liver disease. So as you can see from the left-hand side, you've got normal liver, and with accumulation of fat, it develops steatosis. That steatosis undergoes cellular injury and inflammation, and as well as fibrosis, to form steatohepatitis as well as MASH. Then eventually, this progresses to cirrhosis and hepatocellular carcinoma. On the bottom right of the slides, you can see two histology slides. And the reason why I put this is essentially this histology is from a fatty liver as well as a non-alcoholic fatty liver versus a fatty liver. And you can see the similarities in the two histology slides, which begs to state or reason why there was such a confusion as well as a debate in the terms and descriptions of MASLD prior to this final confirmation. And so just to give a history of where this term came about, it all started in 1836 by our famous Thomas Addison. Now, Thomas Addison was actually known for more the Addison's disease, as we all know, primary adrenal insufficiency. However, in 1836, he described cases of fatty degeneration of the liver, or fatty liver rather, related to excessive alcohol intake. And then in the 1970s, a couple of hepatologists reported similar pathology in patients with obesity and obesity-related disorders, and saw that with the histology and how it looked, there were some similarities. Fast forward another 10 years, in 1980, Ludwig and colleagues from the Mayo Clinic first used the term non-alcoholic steatohepatitis. Now, it was poorly understood then, and it mimicked a lot of alcoholics hepatitis, and also progressed to cirrhosis. And so there was a little bit of confusion with regards to the actual sort of term. Fast forward another 40 years, Eslem and colleagues proposed to rename it to non-alcoholic fatty liver disease as metabolic dysfunction associated fatty liver disease, or MAFLD. Then 3 years later, in June 2023, the nomenclature of steatotic liver disease and the definition of MASLD came about, following an international multi-society guided Delphi process. The main highlight came about to show that the liver disease was actually metabolically related, and therefore MASLD came about. And a lot of hepatology is involved, especially some, including Prof in our country, and this definition then came about. So to summarize it all, it came down to steatotic liver disease. Now, for our topic today, we are focusing on the far left, being our MASLD as well as MASH. But I just thought I would just show you what is on the spectrum, so that we are aware of what we are talking about, and obviously to put everything to perspective when you do see patients. So the first one is our alcohol-associated liver disease. So with alcohol-associated liver disease, respectively, there's 50 grams daily as well as 60 grams daily for females and men, males respectively, and that would term you as an alcohol-associated liver disease. Then you have the specific etiology, steatotic liver disease, as well as the cryptogenic SLD. I'm not going to go too much into this for now because that itself is a presentation on its own, but I'm obviously just trying to highlight that this does obviously exist. And then comes the new combination of MetALD, which is basically MASLD plus an increased amount of alcohol intake. Now, with MetALD, there's either MASLD predominant or there's ALD predominant. Now, that is determined by the amount of alcohol units that are taken on daily average. So, as you can see on the left, MASLD predominant is usually 20 to 30, respectively for females and males. So, if you take less than 20 or less than 30 grams per day, you are more MASLD predominant. However, if you take more than 50 and 60 per day, female and male respectively, you are ALD predominant. So then we go on to our topic of discussion today. So the definition essentially is the presence of hepatic steatosis in conjunction with at least one cardiometabolic risk factor, as well as no other discernible cause for the liver disease. Now, this table essentially summarizes our cardiometabolic risk factors and almost has similarity to our metabolic syndrome sort of definition. So it involves five main domains. The one is obesity and overweight. So for overweight, more than a BMI of 25 kilograms per meter squared, and that is for non-Asian ethnicity, whereas for Asian ethnicity, it's more than 23. The waist circumference is very important, and this is also divided into racial profiles, and that the Europeans have more than 94 centimeters in men, as well as more than 80 centimeters in women, and such goes with South Asians as well as Japanese, where there are specific centimeters for each men and women in terms of their weight circumference. The second category is the dysglycemia or type 2 diabetes. If you are on treatment for type 2 diabetes, it is considered as a risk factor. Pre-diabetic patients as well, with the HbA1c between 5.7 and 6.4, or a fasting plasma glucose of 5.6 to 6.9, or excuse me, a OGTT that 7.8 to 11 is considered as a risk factor with type 2 diabetes in general that is also uncontrolled. And that would be your cardiometabolic risk factor for that particular section. You've got then the third, plasma triglycerides, where you have a reading of more than or equal to 1.7, or if you're on any sort of lipid lowering agents. HDL cholesterol less than 1 in men, as well as less than 1.3 in female, or if you're on lipid lowering drugs. And then lastly, blood pressure. So blood pressure of more than 130/85, or if you're on treatment for hypertension, considers you as having a cardiometabolic risk factor. Now, I'm sure you've seen now in the previous slides, there are subcategories to the MASLD definition. There's MASL and there's MASH. So with MASL is basically steatosis with possibly some mild inflammation. However, with MASH, you see a steatosis as well as lobular inflammation and as well as ballooning, as you can see in the histology slide. So MASLD is a global health problem. We find that it affects more than 25% of the world population, and it is increasing day by day. As you can see in the schematic that we have in front of us here today, a lot of our prevalence is coming from our Americas as well as our Middle East and Asian countries. Africa is actually sitting at 13.48%. However, I will show you in the next slide how this is different compared to the previous image. This image is essentially taken from a study that looked at the prevalence from 2010 to 2021, and they schematically put it as age standardized point prevalence per 100,000. And you can see South Africa, pointers aren't working. South Africa, right at the bottom there, sitting between the 16,000 to 17,000 per 100,000 population of prevalence, which is a bit concerning. In this particular study, they did highlight that it is obviously MASLD is obviously a global health concern with the highest prevalence actually seen in Kuwait, Egypt, as well as Qatar. Raising awareness about risk factors and prevention was pushed as essential in every country, obviously. But in China, as well as Sudan and India, they found that the disease incidence and prevalence was rapidly increasing. So, the natural course of the disease basically, MASLD accelerates the progression of liver disease in patients with ALD as well as chronic hepatitis B, and synergistically induces cirrhosis or hepatocellular carcinoma development. We find that at about around 10 to 30% of isolated steatosis progress to steatohepatitis as well as advanced liver disease. However, the risk is much higher with the presence of type 2 diabetes. And so the presence of steatosis in the general population is not really linked to any clinical meaningful increase in liver-related outcomes. So therefore, we don't do any population-based screening. The natural cause, we find that elevated liver enzymes, especially an ALT of more than 33 in men and more than 25 in women, is associated to liver-related mortality. We find that with the risk of extrahepatic outcomes, we find that the risk increases the more cardiometabolic factors there are. MASLD really wasn't associated with the overall cancer mortality, but it did show that there was an increased risk of hepatocellular carcinoma, as well as certain extrahepatic cancers, namely thyroid as well as gastrointestinal. Now, the risk factors and comorbidities associated with MASLD is very important to talk about, but because this is essentially what you're going to be targeting when you see these patients. But the risk factors as we have here, we're going to be going through individually. So the first one is obesity. Now, just the presence, the duration, as well as the severity are increased with an increased risk of disease progression in MASLD. BMI, visceral fat distribution, and weight circumference, with weight circumference, as you saw in our table before, increases that risk. There are prospective studies described in XCOT-M, which basically looks at liver biopsies that were done after patients had gained 5 kgs. And what they found is that there was a higher insulin resistance as well as more pronounced hepatic steatosis. And when they did a follow-up, they found that there was quite a significant progression to fibrosis, which therefore begs the fact that obesity plays a very, very big role in this disease profile. Obesity in individuals with compensated cirrhosis at baseline are also associated with higher risk of clinical decompensation. We also find that there is a significant association of development of HCC with obesity. The next big comorbidity to tackle is our type 2 diabetes. There's an increased risk of fibrosis as well as HCC development that are found, and many studies are able to confirm this association. Canwell as well as Yang back that they also had a study that showed biopsy-proven MASH as well as compensated cirrhosis over a 5-year period. And what they found in that 5-year period was that they confirmed poor outcomes with 4-fold increase in the risk of death as well as 2-fold increase in liver outcomes, which is quite dangerous and which shows us that we really need to be working on this particular comorbidity in closer attention. The next one is our hypertension as well as dyslipidemia. So MASLD has a high rate of dyslipidemia and hypertension, as we all know, and it's associated with fibrosis progression. There was a large study that I came across in Yang, which basically looked at 271,900 odd individuals. And what they found is that there was a 1.8-fold higher risk of progression to cirrhosis or hepatocellular carcinoma compared to those with actually no cardiometabolic risk factors, which then shows that even this hypertension, dyslipidemia with our type 2 diabetes and all the other sort of cardiometabolic risk factors increase your risk of cirrhosis and HCC. Then I came across obstructive sleep apnea as well as polycystic ovarian syndrome. There are several studies that suggest OSA is associated with more advanced MASLD MASH histology, which then also adds on to the obesity sort of risk factor. With polycystic ovarian syndrome, though it was mentioned, only one study in Asfari mentioned that there was an increased severity as well as advanced fibrosis. Menopausal status, however, was mentioned in that there was a 2.4-fold higher risk of MASLD formation, and with women over the age of 50, they have an increased risk of advanced fibrosis due to MASLD. The next risk factor is ethnicity. Now, there's quite a lot of research going on in this particular domain of MASLD, but over the past 2 decades, there has been a number of genes associated with steatohepatitis. The most famous gene that I came across was the PNPLA3 gene. And what we found is that there's an increase in the risk of MASLD, hepatocellular carcinoma, and cirrhosis by about 2 to 3 times. This may allow us to infer that there's geographic distribution of MASLD in the world. Hispanic population has come up quite a lot, and they're more likely to have MASLD over the a general population. And there are studies to show a comparison in Rich and E et al. Basically, they looked at Hispanics versus Black Americans, and they found that they are more likely to have MASLD, and then later inferred that the PNPLA 3 gene has been found more in these Hispanic populations. So these polygenic risk scores have been essentially developed as well as in order to assess the likely risk of developing MASLD. There's a lot of hopefully treatment sort of guidelines that are going to come out for these genetic associations in the future, but still underway. The next one is smoking. You're at an increased risk of hepatocellular, independent of etiology, as well as MASLD specifically. Now, having gone through all the risk factors as well as the comorbidities, obviously this now puts it all together, and that we need to now figure out a pretest sort of probability of you developing MASLD. And the study by UNICE and NABI basically looks at three main things. One, obesity. Having obesity puts you at a 70% chance of developing MASLD. Type 2 diabetes puts you at a 55% chance of developing it. And with abnormal liver functions, or ALT in specific, you have a 33% of a chance of developing MASLD. When you combine obesity as well as type 2 diabetes, you can see that your risk now jumps to about 90%, which is very significant. Put all three together, and you're sitting at a 97% chance of developing MASLD based on these common comorbidities. And so, in our guidelines, they have spoken about screening of MASLD. And essentially, this is a screenshot that I took from the actual guideline, which basically goes through the screening quite nicely. There are three sort of entry criteria that you have to deal with: either type 2 diabetes, obesity plus one or more cardiometabolic risk factors, as well as persistently elevated liver enzymes. And what they use is our FIB-4 score. For those of you who don't know, the FIB-4 score looks at age, AST, platelet count, as well as ALT. And what it does is that it tells you the amount of, or the risk of advanced fibrosis based on these sort of scores done beforehand. And as you can see, there are three different colors there. There's the light green, the yellow, and the orange. And with our light green, if your FIB-4 score is less than 1.3, the recommendation is that you need to reassess your FIB-4 score every 1 to 3 years. However, there are a few management techniques that need to be done, which I'll be discussing later, in order to make sure that you stay at that level, if not get better. One thing I would like to mention is that with the FIB-4 score, these values of 1.3 actually does increase to about 2 if you're over the age of 65. So that's just something to take note of. So when you're less than 1.3, you become a low risk. If you are between 1.3 and 2.67, you are deemed then as a moderate risk. And then obviously more than 2.67 puts you at a high risk. So if you fall under the moderate risk, you can either go for formal scanning, fibroscanning, or you can just intensify management of your comorbidities and then reassess within a year or 1 year to less than a year, and then calculate your FIB-4 scores and decide whether you become low risk or if you have become worse. And then based on that, you can refer your patients to a hepatology unit, or obviously, if you are able to, you can treat aggressively. Other scores that are used in screening of MASLD are your APRI as well as your NAFLD fibrosis score, but the FIB-4 score is usually quite easy and nice to use. The AGA have essentially come up with this app. You're welcome to scan it on your QR code if you're able to, but basically it helps you in calculating your FIB-4 score as well as being able to determine what you can do from when you've decided your FIB-4 score for your patient. We then move on to the management of our patients with MASLD. And this slide is essentially a nice slide to summarize essentially what we do for these patients. In the previous slide, we mentioned low risk, intermediate risk, as well as high risk. And just to revise, the low risk essentially is when we have a FIB-4 that's less than 1.3 and a LSM less than 8, as well as a liver biopsy that's F0 to F1. Obviously, you don't need to do it, but sometimes when you do have it, it will help you to stratify your patient. So if it's low, intermediate, and high, we treat according to the five points on the side. So one is your lifestyle intervention. What I want you to all note is that with all three low, intermediate, as well as high risk, lifestyle modification or intervention is present for all of them. Weight loss is present for all of them. The CVD risk reduction, depending on whether your patient has it or not, is required for all of them, as well as diabetes care. If you have diabetes, you treat it. The one thing I want to highlight is that under the low risk for pharmacotherapy of MASH, in your low risk, it's not really recommended that you treat it, but we'll be going through it later in the presentation. But I thought that this was a nice sort of summarized version of how you should be thinking when you see these patients. So the general measure of managing these patients would be one, abstaining from alcohol without any doubt, with any sort of liver condition, refrain from alcohol use, particularly, especially heavy alcohol use. Immunizations are important, especially vaccinations, Hep A, B, as we usually do, as well as other additional vaccinations such as your pneumococcal, influenza, diphtheria, and tetanus. So weight loss. So weight loss essentially is our primary therapy for these patients with MASLD, and in most times it helps quite a lot. There's significant improvement in liver biochemical tests, your liver histology, as well as your insulin and quality of life. For those who don't meet the goals within 6 months, we can consider things like bariatric surgery, which I'll be discussing a bit later on. The target weight loss from all of the research that I've done, studies suggest about 5 to 7% loss of body weight at a rate of 0.5 to 1 kg per week. For patients with suspected or biopsy-proven MASH, studies have shown that you actually need to lose a little bit more. So weight loss needs to be sitting at around 7 to 10% of body weight. Several studies have also suggested that at least 5% weight loss is needed to improve. And so I found this nice schematic, essentially trying to summarize how we can go about weight loss in these particular patients. So we've spoken about the top left, but I want to look at the recommendations to all MASLD patients. And diet is one important thing. So the diet quality, they recommend Mediterranean diet. For those of you who don't know what the Mediterranean diet is like, it's essentially the schematic that I put on the picture that I put on the right-hand side. So fruits, veggies, whole grains, extra virgin or virgin olive oil, you can eat every day. And then you can have that at least in 3 servings a week, sorry. Fish, seafood, nuts, and legumes, you limit to one. You can have at least 3 servings a week. Sorry, I think I may have said the other way around, but eat every day for the one on top. Fish, seafood, nuts, and legumes, you can eat at least 3 servings a week. Your poultry, low-fat dairy, as well as eggs, you limit to 1 serving a day. And then lastly, your red meat, obviously your sweets, limit to 1 serving per week. Apart from the Mediterranean diet, obviously we need to limit the amount of processed meat, ultra-processed foods, as well as sugar, sweetened beverages, and then increase your unprocessed, minimally processed food intake. Then physical activity comes on board over here. So with the physical activity, obviously you have to tailor it according to your patient that's sitting in front of you. But the recommendations is that you need to have at least more than 150 minutes a week of moderate or 75 minutes per week of vigorous intensity physical activity. And with this, obviously, you need to try and minimize your sedentary sort of time. So even if it means that you're going to walk or, not watch TV the whole day, that sort of method needs to be pushed. But generally, aerobic or cardio activities is what is recommended, whether it be brisk walking, riding a bike, swimming, or running. That has been pushed quite a lot for physical activity. We mentioned it before, but smoking and alcohol is definitely something that needs to be avoided. So essentially, for weight loss, we have the diet as well as the exercise. But then moving on to the treatment approach to help this, this table sort of summarizes what we need to be doing. There's MASH targeted treatment, as well as treatment that can help it, but we are treating type 2 diabetes, dyslipidemia, as well as obesity. So the first drug that I'd like to touch upon, which is one of the only ones that are FDA approved, is our liver thyroid hormone receptor beta agonists. So most of you have probably known it as resmetirom, and basically this limited availability and is costly. But MASH and fibrosis stage F2, F3, who do not achieve sustained weight loss, can be considered to have resmetirom. Studies have excluded the use in cirrhotic patients. However, there are ongoing trials looking at whether you can use it in cirrhotic patients. But the mechanism essentially is hepatic lipophagy as well as mitochondrial biogenesis. It inhibits lipogenesis and interferes with fibrogenesis by inhibiting your TGF beta signaling. All what it means is that it lowers your LDL cholesterol, it lowers your triglycerides, and it lowers your liver fat, potentially reducing the lipotoxicity. What's nice is that it works on your beta agonist, so it doesn't really cause any sort of thyrotoxicosis because it doesn't work on the alpha. There is the Maestro NASH study, which I'll be speaking about in the next slide. But basically, they recommended from the study that the use of 80 milligrams per ounce daily for less than 100 kilograms and more than 100 kilograms should use 100 milligrams per ounce daily. One needs to have precaution that you need to check all potential drug interactions before use, and the side effects are usually diarrhea, pruritus, as well as nausea. So the Maestro MASH study essentially looked at patients over a 52-week period, and the trial compared resmetirom to placebos, and they found that there was MASH resolution at 52 weeks, improving fibrosis by at least one stage. And you can see this in the picture on the left, where you see placebo sitting at 10, on the 80 milligrams sitting at 26, and the 100 milligrams sitting at 30 for MASH resolution with more than 2-point reduction without worsening fibrosis as well. Then the graph next to it is the fibrosis improvement with no worsening of mass, and basically with placebo it's 14, with our 80 milligrams 24, as well as the 100 sitting at 26. The next treatment modality for MASH is vitamin E. So the mechanism really works on lipid soluble acting as a scavenger. So it works as an antioxidant, anti-inflammatory, and anti-apoptotic properties, and it reduces lipogenesis, therefore decreasing the liver lipid content. There are studies that basically prove that in biopsy-proven MASH as well as fibrosis of stage 2 or more with no diabetes, you can use vitamin E. And the dosage that you use is quite a high dose of 800 units daily, and it's shown to improve steatosis as well as inflammation in such patients. The potential concern for vitamin E is that there are some safety issues with regards to the high dose. Trials have compared vitamin E to placebos, and we've seen that, or studies have shown that there's improvement in global histology as well as ALT compared to the placebo. However, there was note in the study by Daniel saying that we need to avoid vitamin E in men that have personal or strong family history of prostate cancer. The largest randomized controlled trial to date basically looked at non-diabetic MASH with vitamin E for 2 years at 800 units and showed that there's significant improvement in disease activity and steatosis, resulting in reduction in liver enzymes. Then the management of Type 2 diabetes is a big one. Metformin is what we usually use as first line. However, it really doesn't have much benefit in improving liver histology. However, generally, from a glycemic point of view, as well as a weight loss point of view, it has some benefit. The next drug, pioglitazone, has been spoken about quite a lot in that it improves fibrosis as well as inflammation and steatosis. When you compare it to placebo in trials, where they most likely to really improve hepatic histologic parameters such as ballooning degeneration, lobular inflammation, as well as steatosis. We found that in these studies there was improvement in fibrosis that was noted. However, the problem with pioglitazone that came up is that once we had to stop the drug, the benefits reversed. And so for it to be a long-term treatment, it was a bit of a tough drug to use, as well as on top of that compounded with the side effects that we know, which are increased weight gain, heart failure, and fractures. The next drug, which we have probably used quite a bit, is our SGLT2 inhibitors. So it induces arenoglycosuria, helps with weight loss, as well as decreases your blood pressure. It is shown to reduce ALT, especially with empagliflozin as well as lycoglyphosine. The EFFECT-2 trial study showed basically that the use of SGLT2, in particular the dapagliflozins in diabetic patients, resulted in a decrease in steatosis. So also definitely has some potential to help with our patients with MASLD. The glucagon, like peptide 1 receptor agonists, is something that has attracted a lot of attention. It's used in the treatment of obesity and type 2 diabetes, but essentially it is an incretin hormone that is secreted during the postprandial phase by your intestinal enterocytes, mainly in the small intestine, and basically it regulates your plasma glucose essentially. So when you eat, basically it says that you're full, and then you obviously don't eat anymore. It's got beneficial metabolic effects as a result. And there are multiple long-term sort of randomized control trials that basically shows that there's a reduce in cardiac outcome and mortality. But in our particular situation, GLP-1s basically studies look at two, liraglutide as well as semaglutide. So with our liraglutide, there was a trial that I got from Tech and Frack et al., but basically touched on trial of 52 patients for 52 weeks with end of treatment biopsy. And what it showed is that there was MASH resolved on about 39% of liraglutide patients compared to 9% of placebo patients. Patients who were on liraglutide were less likely to also have fibrosis progression. But the bigger one would be our semaglutide that we're seeing a lot of trials and outcomes come out of. Initially started as a phase 2 trial with 320 biopsy-proven MASHs, as well as liver fibrosis of either stage 1, F1, 2, or 3. And what they did is they put patients on semaglutide 0.5 milligrams once daily and resulted in a higher rate of histological resolution of MASH compared to placebo after 72 weeks. So the percentage that they got, as you can see in the pie chart, is 59% achieved MASH resolution, whereas for placebo it was only about 17%. The only issue was that for about 43% of them, they achieved fibrosis improvement, whereas with the placebo, 33% achieved it. So not really so significant from that point of view. But then comes our Essence MASH-3 phase 3 trial. Basically, they took participants with clinically significant fibrosis stage 2 and 3, as well as MASLD, and they gave them semaglutide 2.5 milligrams one subcut per week or weekly. And after about 240 weeks in a double-blinded trial in 1,200 patients with MASH, they basically reached these primary endpoints of improvement of steatohepatitis and no worsening of liver fibrosis. So a lot of promises coming out from our GLP-1 receptor antagonists. And then the last part of our column was dyslipidemia and statins. And essentially, we see that statin intake was associated with the reduced risk of MASLD, MASH, as well as liver fibrosis. The next treatment modality, as was presented earlier, is your surgical and endoscopic therapies. So, for us to have weight loss, bariatric surgery has been recommended, especially in patients with non-cirrhotic MASLD with an approved indication, and in that they weren't able to meet their goals after 6 months of lifestyle changes. So, in the consensus, they basically strongly recommended that they should be considered the non-cirrhotic MASLD. But in patients with MASH or advanced fibrosis without decompensated cirrhosis, if they don't meet their weight goals of 6 months and of life with lifestyle changes, and in particular, they did mention also including 2 nutritional visit counselings. These patients can be considered for bariatric surgery, however, from a case by case sort of method or manner. With bariatric surgery, there has been a promising sort of improvement in histology of patients who have undergone bariatric surgery. However, strangely enough, there are some patients who do develop worsening fibrosis. However, it was few. Therefore, close monitoring of these liver function tests post-bariatric surgery is very important, and we need to monitor for signs of decompensation. With surgery, there are the endoscopic sort of therapies that were looked into. So things like intragastric balloon, endoscopic sleeve, gastroplasty, aspiration devices, Botox injections, and there's quite a long list. But currently now, as it goes, there's a need for further validation of these sort of procedures, and is not really currently recommended as practice for our MASLD patients. Then with regards to end-stage liver as well as transplantation, it is obviously a disease with a lot of comorbidities and a lot of issues that can affect our body. So you need, as with all of our transplant sort of cases, a multidisciplinary team that looks at all the cardiovascular and cardiometabolic risk factors and try to mitigate each one as best as possible. This is obviously just to make sure that the patient is good pre-transplant, around the time of transplant, and obviously post-transplant. So working in hand, this essentially needs to be pushed as much as possible and as close as possible. We need to be treating these comorbidities and risk factors as best as possible. So then in the future, there are a couple of drugs that I found that are undergoing trials and comparisons. Of the list, there's cyclophilin inhibitors, you've got DGAT2 inhibitors, FGF21 agonists, our GLP-1, GIP glucagon agonists. But a special mention I'd like to put towards our GIP, GLP-1 glucagon co-agonist, tirzepatide. Significantly, so far, it shows that there's good reduction in both liver and visceral fat in type 2 diabetes, as well as major weight loss. And there's promising results on steatohepatitis in our trials. To just mention, there is our symmetry trial that basically shows, or they're trying to show, the use of GLP-1 receptor antagonists with FGF21 agonists. And what they've shown also is that there's a potential accelerated regression of fibrosis when used in MASH. So there's still quite a lot going on, and like I mentioned right in the beginning, there's a lot that we have to look forward to in terms of drugs. And so recently, I actually stumbled across this diagram published essentially this year in our MASLD Hepatology Journal. But basically, with the advent of our multiple therapeutic targets in late phase clinical drug development for MASH, there is actually a knowledge gap to better understand the comparative efficacy of various pharmacological agents. So they conducted essentially this updated network meta-analysis to evaluate the relative rank order of the different pharmacological agents for both fibrosis regression as well as MASH resolution. And as you can see, they took about 29 randomized control trials, which basically had about 9,324 patients with MASH. And you can see from the fibrosis point of view, the improvement of 1 stage or more without worsening MASH you can see that you've got some interesting results that are presented there. You can see on the far right your semaglutide as well as your resmetirom compared to your pegopheramines, which are basically F2, FG, F2-1 agents, as well as your mass resolution without worsening of fibrosis, almost the same sort of presentation seen. So there's still quite a lot to come through, and hopefully we'll have a little bit more FDA-approved sort of drugs to use in the future. But it looks like a couple of drugs are coming in the pipeline, hopefully. So just to summarize everything, MASLD essentially is a spectrum of falls under the spectrum of steatotic liver disease, and it has been revised multiple times to be all-inclusive and clinically relevant. And I hope I got that across to you today. More importantly, it is important to screen our patients as soon as possible, as early as possible, because the earlier you treat, as you can see, the better the resolution of both fibrosis and steatosis in general. We touched on a couple of pharmacological and non-pharmacological treatment strategies, and I'd like to obviously, in the last slide, as described, look out for multiple trials that are ongoing, and hopefully will open a lot more to our future in treatment of MASLD. Thank you so much.
Thanks, Midhun. I mean, that was really an excellent overview. And I think really demonstrating that this is really a public health problem and that we're going to need to address it really sort of at primary health care and then move upwards. Can you stop sharing and then we can open it up to discussion?
Prof.
Any questions? So I think what's been clearly demonstrated is the multiple comorbidities that result in increased risk of fibrosis. So if you're looking at obesity, diabetes, hypertension, and dyslipidemia, the more cardiometabolic risk factors you have, the greater the risk of actually having steatotic liver disease, MASLD, but importantly, the increased risk of steatohepatitis and fibrosis. So we really need to actually up our game in terms of actually managing diabetes, dyslipidemia, and hypertension. I mean, I think we all see in our clinics the very poor overall control of these conditions, and that really has to be done at primary health care. And I think if we look at it, we need to really look at improving the access to our appropriate therapeutics that can actually go beyond using metformin and insulin now in terms of managing diabetes. The other thing is the very important. So if you look at steatotic liver disease and you've got MASLD, you've got MET-ALD and ALD, if you look at the risk of fibrosis, obviously the highest risk of fibrosis, cirrhosis, and decompensation is with alcohol-related liver disease, followed by MET-ALD and then MASLD. And I think it's important to realize that with MASLD, there's really no safe alcohol. There was quite an interesting study that showed that if you had simple steatosis and you had one drink a day, that in fact decreased your overall life expectancy by about 5 years. So I think it's something that we really need to really discuss with our patients. I mean, alcohol really is a way of life in South Africa, and so we really need to stress the importance of actually abstinence. Any questions or comments? I mean, I was at a meeting on SLD earlier this year, single topic meeting, and one of the interesting things that came out in terms of the bariatric surgery was that, in fact, what it was associated with quite a high risk of alcohol-related abuse. And so, in fact, although one controlled the weight loss, they had quite significant alcohol-related liver disease. And so really re-emphasizing when you're actually embarking on bariatric surgery, you need to have really quite significant psychiatric assessment. VG, you've got a hand?
Hi, Wendy. Yes, I fully agree with everything that's been said so far, and excellent your overview of like MASH and SLD in general. I just want to bring it back to, you spoke to we're going to have this huge health problem with fatty liver, and I completely agree with you about screening for the hypertension and control sugars and everything at like primary health care. But specific to fatty liver itself, few issues. How do we screen South Africans for fatty like liver? And the algorithm that was placed up over there seemed to emphasize screening for like in liver stiffness. I'm assuming these are in areas in the world where FibroScan, you're registered, the proper machine is widely available. Now that's not quite applicable to here, and I would suspect many areas in the world. So how do we sort of sort out both screening and stratification in the absence of having easy access to FibroScan at a regional hospital level, even?
Absolutely. I mean, that's a very important comment. So, I mean, I think one needs to increase the awareness of the risk of steatotic liver disease, MASLD, in the setting of those risk factors. And then I think we need to be looking at using the FIB4. So really what you need there is the ALT, the AST, age, and platelets. And so that should be easily accessible if you think that at primary healthcare level, you're going to be monitoring glucose, A1C, and collect. So I think we need to actually increase the understanding of FIB4 being a screening technique. And then, as Midhun said, if it's below 1.67, these are patients that you can stay at primary healthcare, but you need to upregulate the management of those cofactors. If you have that between 1.67 and 2.67, what they recommend there is that you look at doing a second test, which is the FibroScan or the ELF test. Now, as you rightly say, in fact, there's only a few of the academic centers who have access to the FibroScan. And I think once again, there you're going to look and see what is their overall risk in terms of their liver profile, what are their platelet counts doing, and see whether you can actually just upscale management or whether you need to refer it upwards. I think the FibroScan is something that helps us, particularly at tertiary level, and it avoids the need for a liver biopsy. But once again, we need to be looking at motivating to how we can get the prices down for the mobile FibroScans. But I think the FIB4 is a very useful sort of screening criteria right in the beginning. And another way to actually, I think, to increase the access of that is for this to be automated, just like when you get an HbA1c or lipid profile, they'll give you the risk factors, what your risk of having an MI is, whether it's poorly controlled diabetes. So that's one way of actually increasing the awareness at healthcare level. So Viju, did that?
Thanks, Wendy.
And then I think there's another question. I think there was another hand up.
That's Neo.
Hi, Wendy. Yeah, it's Neo.
Hi, you want to go for it?
Yes, thanks. So yeah, just to add on to what you said now, I think education is very important, especially because a lot of these people with these metabolic risk factors are managed in the primary healthcare areas. And I don't think a lot of people who actually look after these patients know about fatty liver disease. So I think it's very going to be up to us to somehow get the message through to them that these are the basic tests that you can do to see if the patients you're managing have got these fatty liver or not. And then, because the other thing that I've seen in practice, especially when it comes to managing cholesterol, sometimes you find that the patient has deranged liver enzymes, and GPs would be scared to start statins because they believe that statins are hepatotoxic. So that will be another thing going against trying to control this thing. And yeah, just lastly, to just get your thoughts on, the ELF test. Do you think is comparable to FibroScan? Is it something that's available in your center?
So thanks, Neil. So absolutely, I think we need to look at educating I mean, everybody's well aware of the cardiovascular risk factors associated with poorly controlled diabetes, dyslipidemia, but we need to include MASLD in our education, and that really needs to start at the level of our students at the medical curriculum. In terms of the ELF test, it's recommended as a second-line test. It's probably equivalent to the FibroScan, but it's very expensive, and we don't have access to that. And so the recommendation is if the ELF score is greater than 7.7, that's a sort of red flag for cirrhosis. But in reality, I don't think we're going to have access to that. It's really quite expensive and not easily available. Sorry, Nay, was there another comment that I didn't?
No, just the statin thing, but it goes back to educating medical students.
Yeah, I think absolutely. I mean, all of us have probably been guilty in the early phases of actually not wanting to use statins in the setting of chronic liver disease, but it's been shown to be safe. And if you're monitoring the patient, it really is not a contraindication. And in fact, it actually is beneficial in terms of preventing progression to fibrosis and cirrhosis.
Wendy, I think there's a few questions in the chat.
Okay. Sorry. Okay. So one of the ones from Pascal Kuka, any demonstration risk of MASLD recurrence post-transplant, particularly since risk factors may be persistent. I mean, that's very important. In fact, before we understood about MASLD cirrhosis and losing the fat from the liver at the time we actually developed cirrhosis, in fact, these patients were transplanted, and then in fact they were labeled as being cryptogenic, but in fact 30% of them were due to what we now know as MASLD. And one of the problems is that if you didn't address the underlying risk factors, the recurrence was actually quite rapid, often within 6 months. So very, very importantly that one needs to actually address those problems. I mean, one of the things that we see in our program is that the patients are, they get set a target to get a certain weight before they're accepted onto the transplant list. Very good. And then they feel a lot better after transplantation, and they can rapidly gain weight back to their sort of pre-morbid transplant setting. So I think it's very important. We need to be more holistic in actually involving dietitians, behavioral therapists, and physiotherapists in these patients, because the recurrence can be very rapid. I think Bilal's on. He might want to comment as well on the recurrence.
Thanks, Prof. I think one. Sorry, I joined late, but I think one of the most important aspects here is regarding lean muscle mass in these patients, and trying to get them to restore that. MASLD at its heart is a disease of insulin resistance, and one of the best ways of improving insulin sensitivity is by increasing lean muscle mass. So that is something that we certainly push with our patients in terms of resistance training very shortly after they've recovered from the transplant, and a guided return to physical activity is encouraged. BG, I'm sure you're seeing a lot of lean NASH in Durban. It is particularly common with patients from of subcontinent extract, where you have individuals that may even be of low or normal BMI, but have significant metabolic risk factors, including diabetes, and that can often be attributed to their low muscle mass. So I think that's just, as Prof. Spearman has pointed out, this is a multifactorial problem that needs therapies at multiple different levels, and resistance training should be encouraged. There's something called an exercise script that is being talked about for these patients, which should be encouraged.
Thanks, Bilal.
Thanks,
from Mazama. Very importantly, MASLD we know is an increased risk for HCC in the absence of advanced fibrosis and cirrhosis. And so what are the recommendations for screening in these populations? So there's no clear guidance as yet. In fact, most of the EASL hasn't actually, and ASLD hasn't recommended formally that you screen for HCC if you've got advanced fibrosis. But in practical terms, if you've got advanced fibrosis, we actually screen on a 6-monthly basis. So they haven't changed that, although we know that you don't have to have cirrhosis in the setting of fibrosis and steatohepatitis to develop HCC. So our recommendation is that you would screen as you would for cirrhotic patients. And then from VG, any comment and recommendations regarding the role of liver biopsy in this condition? So I think the liver biopsy, importantly now, with the non-invasive tests, we really don't need to do a liver biopsy. There are certain indications. So, I mean, our sort of practice is that if you have positive autoantibodies, we know that, particularly in ANA, we know that with steatohepatitis, often the smooth muscle antibody is positive. If the ANA is positive, it can be positive, but then we would usually err on the side of doing a liver biopsy. And my sort of feeling is that if the ALT and AST above 150, and with sort of 3 months of attempts to improve lifestyle with no improvement, those patients potentially require a liver biopsy, or if there are other factors concerning in terms of exposure to drugs and toxins. So it's usually on an individual basis, but importantly now also in the trials, they're looking at seeing whether one can look at non-invasive markers to assess for fibrosis rather than relying on a liver biopsy, which will increase the access to clinical trials.
Hi, sorry, Wendy, just to add on from that regarding the role of your liver biopsy, your experience with these individuals who are very large and fat, basically, they're overweight, to try and do a percutaneous biopsy can be your biopsy needle may not even reach there. I mean, you guys starting to explore the options of EUS, liver biopsy, endoscopic ultrasound.
We haven't done that as yet, VG. We seem to have a very successful interventional radiologist who seems to have very long needles, but we've probably then rather gone the transjugular route, which is what our sort of we have access to. But absolutely, they can be very challenging. There's another question, the role of, I think it was it? Did I see a question on ursofolk? That's what I saw.
Yes, there's a question on urso-liv. I'm not sure if it's the same.
I think it probably is ursodeoxycholic acid. So sort of in the late 90s, early 2000s, ursodeoxycholic acid was put forward as a potential treatment, but really hasn't been shown to be of any benefit. Any other comments or questions? So, I mean, I think we can see, I mean, it really was an excellent talk by Midhun, really covered all the important aspects of this really overwhelming public health problem. And I think what we need to be looking at is really expanding our teaching programs to primary health care, just like they do it for diabetes and hypertension. We need to add MASLD. We need to take it to the forefront of people's really knowledge around the risk when you have significant comorbidities. And I think if you look at that map that Midhun showed you with the MASLD, very significant prevalence in South Africa and then in North Africa. But in reality, we probably have little information in terms of the rest of Africa, and bearing in mind the obesity, but particularly the rising problem of diabetes and hypertension across the whole continent. I think this is a problem that's really underestimated. So, Midhun, thanks very much for really an excellent presentation. Thanks for all the interactions from everybody and the comments and contributions. And so really just needs to thank ECHO University in New Mexico and the ECHO India team for their support. The recording will be available on the Gastro Foundation website. And as always, we thank Gastro Foundation for really supporting these webinars. Our next presentation will be on the 14th of April. And that'll be by Sandy Masenya, with the facilitator being Mark Sondrup. And this will be alcohol-related liver disease. So thanks, everyone. And really thanks, Midhun, for an excellent presentation.
Thank you, Prof. Thanks, everyone.